Welcome to the AICT-AsiaPCR On Air 2020 Boston Scientific Sponsored Symposium on Optimized Complex PCI Outcomes through Innovative Technologies. In this particular symposium, we have the following agenda. We want to talk about the learning objectives, and this is followed by a complex PCI case presentations from the National University Heart Center, Singapore. And then there will be a question and answers with audience who will be attending these sessions. And then we're going to have a talk given by Dr. Honye on Ivas guided PCI for complex PCI, followed by a concluding remarks. So my name is Huay-Cheem. I'm from the National University Heart Center, Singapore. With me as the co-faculties will be Dr. Goran Stankovic from Belgrade, Serbia, Dr. Rosli Muhammad Ali from Malaysia, and Dr. Junko Honye from Japan. In this particular symposium, we have the following learning objectives. We want to learn about the new SYNERGY XD stent, which has just been made available in Singapore. We want to learn also about the use of this SYNERGY XD with this Platinum Chromium unique architectural design for bifurcations lesions, particularly left main stenosis. And we also want to learn how the use of intravascular imaging can help in complex PCI. And let's talk about SYNERGY XD briefly here. We know that SYNERGY XD really is built and designed based on the known architecture of its biodegradable platinum chromium design. So there's no change in terms of the stent platform as well as the polymer coating. What is different here is the enhanced deliverability systems, where the hypotube now is being extended by about 3 centimeters. And so the wire port that is coming out from the distal shaft is now pushed more distally. And the entire mid shaft is also coated with a lubricious coating, and this allows for easy trackability. At the same time, the packaging has also been changed. Instead of double packaging, which you may not have realized before, now it's a single packaging. You just tear it open, you can get the stent for use. So the SYNERGY XD actually optimized the mid-shaft for deliverability by enabling a flexibility to navigate tortuous vessels such as in the subclavian or in the aorta. So it also helps to transmit the push force with this extended the length of the hypotube, and it reduces friction in the subclavian artery and allows for enhanced force transmissions and trackability. And finally, it minimizes shaft kinking in a stress relief sort of a fashion between the stiff end of the proximal, between the proximal end as well as the flexible distal shaft. On top of that, if you look at the hub, now it's actually much easier to look at the sizing as well as the length of the lesion with this new enhanced visible feature. So when we consider a stent for left main, we always like to have the following characteristics in mind, that this stent must have sufficient radial strength. It must be able to expand it to accommodate the large caliber vessel, oftentimes seen in left main vessel. Side branch access has to be very good, and best also radial opaque, visible, so that we know exactly where the stent is being positioned. And when we look at the platinum chromium stent radial force, and in all these bench studies have clearly shown that is of a higher radial force compared to a cobalt alloy as well as a stainless steel stent. What is also important from the SYNERGY X stent is that we know that the strut width is actually more important than the strut thickness, and the strut width, which is wider here, allows for this rounded stent design of the SYNERGY to be enhanced greatly in terms of its radial strength. Also, when the stent is being expanded to its large diameter, the radial force actually increases as in this bench test performed by Dr. Pham from Singapore. So what we do know also from the stent SYNERGY is that the normal usual stent can be actually expanded to a very large diameter. A 3.0 stent can be expanded to a 4.2, and a 4.0 stent can be expanded into a 5.7 millimeter. On top of that, the SYNERGY XD stent has got enhanced axial strength in its proximal segment with the additional connectors at the proximal rings. The rest of the other stent actually has got two connectors, which allows for easy flexibility and conformability. But the increased number of connectors in the proximal end enhances not just the axial strength, but also the longitudinal strength to avoid stent deformation. And we also know that platinum chromium is probably the most radio opaque, most visible on X-ray compared to the other second generation drug-eluting stents. And we know that stent placement is so important, particularly covering the ostium of the left main to avoid restenosis. So we also will be talking about the use of OptiCross 60 megahertz. This is a new device that is being introduced by Boston, and this provides an enhanced resolutions both in the axial fashion as well as in the lateral resolution fashions. And if we look at the 40 megahertz pictures and compare to the 60 megahertz pictures on the right, you find that the enhanced resolutions is quite obvious in these two different Ivas catheter. So, and we know that the use of Ivas catheter in the ultimate trial follow-up for 3 years has got a significant improvement in terms of target lesion failure compared to no Ivas guided PCI. So right now we are going to go into a interesting case sharing to see how the new SYNERGY XD stent perform in a very complex bifurcations stenting case. I have no conflict of interest apart from receiving honorarium from some of the companies. So the case that we're going to be presenting today is a 66-year-old gentleman with previous history of stroke in 2000 as well as 2013 with significant residual right hemiplegic and dysphasic neurological symptoms. He was admitted with non-ST elevations myocardial infarction, which was complicated by acute pulmonary edema. The two-dimensional echocardiogram showed a severe left ventricular systolic dysfunction with EF of 25% and the presence of a LV apical thrombus. Nuclear viability showed a viable myocardium in the RCA and the LAD territories. However, the myocardium in the circumflex territory was predominantly infarcted. And patients had a heart team discussions. Surgeons deemed that the bypass surgery was just too high for this particular patient, given his neurologic history and underlying LV function. When we look at the syntax score 1, it was 41. The PCI syntax score 2 was 66, and 4-year mortality was 78. So this is a really high-risk case here. When we start looking at the angiogram, this is a right coronary angiogram. You can see that there's a high-grade discrete proximal RCA stenosis, followed by a fairly diffuse segment in the proximal RCA as well. When we go to the left coronary artery, there is diffuse proximal and mid-LAD stenosis. What is of significance is that you can see a very calcified proximal LAD stenosis, which is followed by a post-stenotic aneurysm. And this is followed up by a distal diffuse high-grade LAD, mid-LAD stenosis. On top of that, in the RAO caudal view, we can see that there is also a distal left main disease involving also the ostium of the LAD as well as the osteo of the circumflex artery. So indeed, left main and triple vessel disease that we are dealing with. So in summary, this is a gentleman, 66-year-old with multiple stroke and severe triple vessel disease and poor LV function. This is a complex lesions, and I would like to invite Dr. Goran Stankovic to give us his comment on the following questions. Which vessel to treat first? Is it the RCA or the LAD? What sort of lesion preparations is needed? What sort of bifurcation strategy will you undertake? Is intravascular imaging necessary here? And what will be your pharmacologic regimen for this particular patient post-operatively?
Thank you very much, Prof. Thank you very much, Prof. Tan, for kind invitation to participate and for sharing this extremely complex case. If that case is done in my cath lab, because of the tightest lesion and relatively discrete in the proximal right, and then relatively diffuse segment, but not so tight, I would start by fixing first the right coronary artery. Does not seem to be too complex in the setting of left main and 3-vessel disease. Then switching to left coronary artery, what is for me the first impression, we know from the nuclear study that there is scar in the lateral wall, so I would fix mainly left main LAD, and there are 2 bifurcation lesions. The more complex one seems to be at least a geographically calcified lesion, LAD diagonal with aneurysm, which makes this lesion very difficult to wire. And then distal left main, which seems to be angiographically intermediate. But in the whole setting, I think first it's very important to consider prophylactic balloon pump in my lab. Then I will do 6 French radial. Of course, this is the standard strategy, as I don't expect to have a complex strategy for bifurcation treatment for both lesions. For both bifurcations, my strategy would be provisional, wiring both branches, predilating only LAD, and doing POT. After doing POT, I would reconsider if there is no flow compromise in diagonal. I will not do kissing, and then fix the same way provisional strategy with POT, distal left main. In my view, again, lesion preparation depends on the imaging, but seems to be either cutting scoring or simply non-compliant balloon predilatation of the main vessel. And for the role of imaging, I think will be extremely helpful in this case. Pharmacological regimen in my lab, because of the LV thrombus, will be triple therapy for 1 week, probably, with warfarin, and then after 1 week, switching to single antiplatelet therapy and anticoagulant.
Thank you very much, Goran. Indeed, this is a complex case with so many dimensions to consider, not just from the strategy of standpoint, but also from the pre as well as post-operative care. So let's see, what did I do? So I actually started the procedure by putting in an intra-aortic balloon pump for the patients. And I also put in a pacing wire just in case I need to do some rotational atherectomy for this patient. And I went by the femoral route because I wanted to give myself the best support possible. And I took on a 7 French unplugged left to start with the RCA lesion first. I thought I would deal with the RCA first and then come back and do the LAD because the RCA looks really tight here. But lo and behold, when I engage the right coronary artery, you can see that immediately I've created a complications. There was a osteo-RCA dissections, and the dissections seems pretty extensive. And at the same time, there was still some flow, but and the flow seems fairly okay, and patient was at this point in time asymptomatic. So I got a little bit concerned. So I decided that perhaps maybe I wouldn't touch this RCA and try to salvage it for now. I would just go to the LAD and treat the LAD. And so if I can get away with a successful LAD, then I might just come back and do this again. So I went to the LAD instead, and again, I had tremendous difficulty. The difficulty was encountered in the wiring of the LAD lesion, simply because it was a very calcified lesion. There was an aneurysmal segment. The wires keeps going to the diagonal vessel, and there was no way I could direct it to the distal LAD artery. And this is despite trying several wires run through filter FC, even using a stiff wire here. This was backed up by a microcatheter. I even used a crusade catheter to try to engage. And in this particular view, you can see that the wire actually entered into a dissection segment. So I was in serious situations here because I'm in the situation that is worse than before the operation. Because of osteodissection of the RCA, I can't wire the LAD artery. And I put out everything and I repeated the shot. There was still forward flow, but the forward flow in the LAD artery was slow right now. So situations is not looking good. So I was going to ask Dr. Rosli, what would you do next, given that the RCA is compromised, LAD cannot be crossed? Should we give up and call the surgeon whom they already turned down the operation from the very beginning, stop the PCI, call another person like yourself, or keep trying the LAD, knowing that I've already tried 35 minutes to wire a lesion, which is very uncommon? Or maybe go to RCA first and try to do a LAD at a stage setting. So Dr. Rosli, I would like to hear your input at this stage.
Thank you, Huay-Cheem. This is certainly very difficult because trying to wire in an aneurysmal segment is always tough, and you have showed that it was tough. So it depends on how much you think you can actually do it. But if I were to be allowed to be given a chance, I would actually pull out a hydrophilic wire like a Filder XT wires. And these wires are very sleek, and they have a higher chance of getting down into the vessel. In fact, if my wire goes into the diagonal branch, I would probably keep the branch there, the wire in the branch, and then pull out a Crusade microcatheter or another microcatheter with the second wire to try to then pass the wire down into the LED. Once again, it's very important to see how compromised the flow is inside the LED to the LED, because if it does, then you may have to take the action of wanting to stop. Then if I'm in that situation like what you are now, and if that hydrophilic wire fails to go through, I will go back to the right, at least secure the right, and at least you know that if you are able to treat with the right, then you will have a much more stable patient, and then you can then think about attempting the LED again, whether on the same sitting or a different sitting. And to be safe, one would want to consider a stage approach, do the right, bring the patient back for the LED.
Thank you, Rosli, for the comment. I'm just thinking whether the, because the lesion was so tight in the LED, just putting a wire in the diagonal may not have enough space for another wire to actually go down the LED artery. But nevertheless, I actually followed your line of thoughts. I actually went back to the RCA again, thinking that if I can at least salvage the RCA, and then we can always think about the LED either immediately or in the next setting. So I went back to the RCA again. This time around, I used a less aggressive guide like a JR4 guiding catheter and managed to actually engage the lesion and pass the wire successfully into the true lumen distally and managed to pre-dilate the lesions. And this is the picture of the RCA after pre-dil. And then I take out this new stent called the SYNERGY XD stent, known for its extra deliverability, a fairly long stent that I use here. There was still difficulty delivering this stent because of the poor guide support and the tortuosity of the proximal RCA. Nevertheless, with the use of a guide extension catheter, I was able to introduce the SYNERGY XD stent down into the mid RCA segment. And this is where I start to do a sequential delivery and overlapping deployment of two SYNERGY XD stents to cover the proximal RCA all the way back to the ostium of the RCA. And at the end of which, I managed to secure the RCA artery. Having done this, I gained in confidence. I decided maybe I should just go back to the LED since I already put in the balloon pump and pacing and everything has been put in the position. I really hate to stop it. So I went back to the LED again. And this time around, I decided to do something different. So I noticed that the wire was able to pass through the proximal lesion and it tend to form loops inside the aneurysm. And I decided, hey, perhaps I can actually loop this wire so that the distal end goes to the distal LED artery. And this was the only thing that was different from what I did beforehand. There I was willing and to undertake the risk of having a wire to loop inside the aneurysm and go down to the distal LED. And I was actually quite lucky because in so doing, I managed to pass through the wire and straighten out the entire LED artery. So now that I've gained access to it, I quickly did a balloon pre-dilatations using a non-compliant balloon because I didn't know how tight this lesion was going to be. Angiographically, it looks really calcified. But once I have achieved balloon pre-dil, I proceed to do Ivas. And this is where I'd like to invite Dr. Honye to comment on the Ivas images of the LED after balloon dilatation.
Okay, thank you, Dr. Tam. Okay, you can see the Ivas image, and you can see the calcium on your right-hand side. But it locates eccentrically, not circumferential. So once you created dissection with NC balloon, then that lesion would be nicely expanded following stent expansion. And this calcium, the surface is very irregular, and so that calcium probably very thick. However, the opposite side, very healthy area can be seen. And so in that case, the pre-dilatation is important. And of course, you don't have to use rotablator. And the left main, and the area of the left main, the cutoff value for ischemia is 4.5 square millimeters. And I don't know this time, right now, which lumen area of the left main. Okay, thank you.
Thank you. So indeed, I did a MLA measurement of the distal left main. It measured 3.1 square millimeter, so it is considered to be ischemic, possibly ischemic, given that this is a fairly tight lesion. The mean LAD was even tighter at 1.89 square millimeter. So the Ivas does offer some very important information. What bifurcation strategy should I adopt, and what would be a stent choice? Now I'd like to invite Dr. Goran Stankovic to comment on the strategy and the stent choice.
Thank you very much, Prof. Tan. As I said in the beginning in my introduction, because of extreme complexity of the case, I would try to go with the provisional strategy for both bifurcations. First, because I think that putting two-stent strategy in patients with low EF and already present thrombus may increase the risk of complications at follow-up. So I would consider provisional with the simplest step of proximal optimization for both lesions. For diagonal, because I think it's a long diffuse disease of diagonal, and if we predilate, we may risk to increase dissection and then compromise flow completely. So for diagonal LAD, provisional with pot only, and for distal left main, I will predilate towards the LAD, stent towards the LAD, and then decide if flow is not compromised towards the circ, I would again stop because of the scar present in the lateral wall. If we compromise the flow, in that case, kissing, and after kissing, if flow is TIMI 3, I will stop again after kiss. If necessary and flow is compromised, I will put as a T or tap stent in the circ and repeat kissing and pot.
What about the stent choice?
Stent choice, in case of discrepancy in diameter, extremely important discrepancy between left main and the ostium of the LAD, I will select the stent which has two connectors, preferably because of the open cell design, and then with good radial strength and expansion capacity, maximum expansion capacity is mandated in order to fully oppose stent in the left main. So I think, again, SYNERGY XD would be excellent choice.
Thank you, Goran.
Thank you.
So this is actually what I did. Pretty much in line with what Dr. Stankovic has just mentioned. After balloon pre-deal, I decided to adopt a provisional stent strategy. I didn't even put a wire into the diagonal. I just don't think I can get it down. So I did, again, sequential delivery and overlapping deployment of two SYNERGY XD stent extending from the proximal LAD all the way into the left main artery. And this was followed by a port in the left main artery with an NC balloon of 4.0 by 8 millimeter. And this is the final result. Looks pretty good here. The circumflex appears to be intact. So is the diagonal branch. And when I look at the spider view, again, the circumflex is still flowing okay, although there is an osteostenosis, but this does not appear to be compromising flow. And the repeat intravascular ultrasound shows an improvement in terms of the MSA in the LAD, which is now measured at 4.1. And in the distal left main is 8 square millimeter. So all in all, the patient had a successful PCI to the RCA and LAD. So in conclusions, my take from this particular case is that treatment strategy is important before the procedure, but one has to be prepared for a dynamic change in terms of strategy during the procedure itself, because things can just happen according to, not oftentimes according to your plan. And provisional stenting is a default strategy in most of the bifurcation lesions, including the left main artery, best guided by intravascular imaging. And SYNERGY XD is a good stent to use for left main PCI simply because of its radial strength, its expansile characteristics, its radial opacity, side branch access, and is now added enhanced deliverability with this new XD design. So with that, thank you very much for your attention, and I'd like to thank all my faculties for your active participation in this case discussion. So right now, we would like to actually welcome questions from the audience with regard to this case, and then if you do have any, please submit it. So, so to my fellow faculties, you have seen the case, and Goran, one of the questions from Vivo was, why do you want to use anticoagulants? I think there was mention about your triple antithrombotic regimen. I think it was because of the LV thrombus we were talking.
Yeah, exactly. You are right, patient, because of the LV function and because of thrombus in the left ventricle was already anticoagulated. So because of PCI and use of simple strategy, single stents without overlap, without complexity, I think we can do standard as recommended, at least in my country, by European Society of Cardiology guidelines, short-term triple, and then switch to single antiplatelet and continuous anticoagulation.
Rosli, there's a question talking about whether we should use intravascular lithotripsy as a strategy here for calcified lesions. Do you think this is an appropriate strategy here?
Yeah, I think what is important is that the Ivas that you did, and the Ivas did not show an extremely severe calcification. So it is not more than 270 degrees. And with that, no indication. There's no indication of saying that we should use lithotripsy here. And I think it's not going to be useful for that modality. And you've showed that in your pre-dilatation, you get fairly good and balloon expansion. So I think we can avoid using that technology.
So Rosli, the reason why I use a one-stent approach for the distal left main was because I know that the circumflex territory was infarcted. Now, assuming that was a viable territory, would you have done the same, or would you have considered a two-stent approach here?
No, I totally agree with you in the sense that and also Goran, because I like to think that the one stent strategy is going to be the best if we can. And I did not think that it was extremely severe or critical lesion. At the most, if I do, I will probably just open up the stent struts and be careful with it and not try to do any much more than that. But if the vessel is really large, it's really true bifurcation lesion, then one might consider treating that.
The circumflex artery does look large. Would you have done the kissing balloon inflation if it's viable? I mean, to talk about whether we should do routine kissing even for a provisional approach, or would you have done it?
On a regular basis, I would see the results. If the results are good, it's not really pinch, and I tend to leave it alone, because even if, let's say, you see that what you think is going to be significant, but when you use Ivas or FFR, it's not going to be so. But if, let's say, it is something with worrying, then yes, I would do a kissing. But the kissing for the circumflex, I tend to undersize the balloon because I don't want to cause a dissection if, in my mind, I'm going for a single stent strategy to start off with.
Actually, when I look at the Asia-Pacific consensus on bifurcation stenting, our colleagues actually do not recommend a routine kissing balloon inflations. They were concerned about oversizing of the stent, particularly in the proximal segment. They're also concerned about perhaps elliptical deformations of the stent. So unless it's absolutely necessary, otherwise most will just leave it alone. Can I ask Dr. Honye, is the Ivas MSA important here? We talk about 5, 6, 7, 8 MSA as being the optimal Ivas results to attain. Do we really have to chase these numbers?
Yes. In some limited cases, those numbers cannot be achieved, especially in heavily calcified lesions. But as long as a lesion perforation has been done adequately, then those numbers can be achieved. And if you feel that the endpoint 5, 6, 7, 8 square millimeters endpoint, then the instant restenosis rate was very low. It's very, very low. So try to achieve those numbers, I recommend.
Dr. Honye, one of the questions that comes in here is that with this 60 megahertz of optic cross, can we now measure the depth of the calcium, just like an OCT?
No, not actually not. And even using 60 megahertz calcium, because of the nature of the ultrasound, we cannot measure the thickness of calcium. However, there are some point to speculate the thickness of calcium. For example, if you recognize the calcium on angiography, and then those calcium could be very, very thick. However, even though you see calcium on Ivas, then that calcium cannot be recognized in angiography. Then those calcium could be quite thin, smaller, thinner than 0.5 millimeters. That means the good stent expansion can be expected. So angiographic calcium detection is very important to estimate the thickness of calcium.
Goran, one of the questions was the choice of anticoagulant. You mentioned about warfarin. One in the audience would like to know, is NOAC a reasonable alternative here?
It is, but I was speaking about our current practice and at least my personal, I think it's important to individualize and to use the therapy that you are experienced with, and I will just continue since patient was already on warfarin, I would continue warfarin. But of course, we have also possibility to switch to NOAC.
Dr. Honye, in the Excel Ivas sub-study, according to Dr. Manish Agarwal, the MSA in the left main was 9.8 square millimeter. So should we even go beyond the 8 square millimeter and try to achieve an even larger MSA in the left main?
Yeah, it depends on the case because we have to measure the original left main size of the vessel. It depends on the patient. In patients with a quite smaller left main, then the 8 square millimeters could be the maximum. However, some patients have much larger left main, and then the endpoint should be larger. So it depends on each patient's native vessel size.
No, I do agree. I think Asians do have a smaller stature, body mass here, so I think we can accept a smaller MSA compared to XL, which is a largely Western populations. Rosli, you have something to comment?
Yeah, I agree fully because Kang's paper, I think, is quite important to help us to guide. But as Dr. Honye said, that it depends so much on the vessel size. So if the vessel is not large, that will be sufficient. But if you've got a large vessel, then you should aim to go as much as you can. Because I had one case recently, I thought I had a reasonable results from Ivas, from Kang, slightly better than that, but the patient actually came back. So, and we treated and make it to an appropriate size. So I just want to reemphasize the point that those are just guide, but if you have large vessels, you should aim for better results.
Goran, what do you think of SYNERGY XD as a choice here?
I think it's excellent.
His performance in this case.
Yeah, I think this is extremely important, and this is one of the tables that we currently use in our lab with the expansion capacity, and having that kind of expansion capacity to use large stent and go up to 5.7, 5.8, it's, I think, extremely important. And I will fully support Dr. Rosli and Dr. Honye comments that image guidance can help you fully expand and fully oppose stent. And the most important difference between left main bifurcation and other bifurcation is that discrepancy between left main and the ostium of the LAD. And in that case, you need to achieve full expansion, not only in the LAD, but also inside the left main. In case you don't have such an expandable stent, you need to use a larger limit diameter stent, deploy at low pressure in the ostium of the LAD, and then fully oppose and expand. And I think availability of the stent like SYNERGY XD is extremely important addition to our routine left main PCI devices.
Rosli, maybe I'll give you the last questions. Audience is asking, what are the problems dealing with aneurysmal lesions, like this case here, in the PCI setting?
Well, of course, number one is that you're concerned about being able to wire successfully, and sometimes can cause dissection. Obviously, the choice of wire is also very important. One may want to have a more stable wire, and you pick up a stiffer wire, and therefore a stiffer wire can cause perforation. And last but not least, I think in terms of results, what is important is to try to ensure that you get good results. Now, if the aneurysm is quite large, you will never be able to size the stent to the vessel wall in the aneurysm site. And to me, I think you should not try to attain that. You make sure that the results in the distal and proximal vessel is good, and therefore you have a tube that has a linear flow. Because otherwise, if you try to match it up, there will be a lot of flow which is slow, and that can also cause thrombus formation. So try to get good results as much as possible, and try to size it according to the proximal and distal segment, not to the
Excellent comment. Excellent comment, Rosli. So in fact, this aneurysm became smaller after we stent across it. Yeah. So for small aneurysmal segments, sometimes it's okay to just deal with it. So very nice. I'm going to go on to the next program, which is a lecture to be given by Dr. Honye on Ivas guided complex PCI.
Thank you, Chairpersons. Good afternoon, ladies and gentlemen. This is my disclosures. Recent ultimate trial has demonstrated that Ivas-guided DES implantation significantly improved clinical outcome in all comers at 1-year follow-up. As you may know, the ultimate trial is a randomized multicenter trial done in China. They included 1,448 patients to look at MACE at 1 year and 3 years as well. Ivas defined criteria were quite simple. Minimum lumen area in the stented segment greater than 5 square millimeters or 90% of minimum lumen area at the distal reference. Plaque burden 5 millimeters proximal or distal to the stent edge, smaller than 50%. No edge dissection involves media with a length longer than 3 millimeters. This is the result of 1-year follow-up. Ivas-guided DES implantation significantly improved clinical outcome in all comers, mainly due to significant reduction of clinically driven TLR or definite stent thrombosis. 3-year clinical follow-up was presented at TCT this year, saying that significantly better outcome in Ivas-guided group. Ivas in bifurcation is useful to predict side branch occlusion, to evaluate plaque distribution. Guide wire crossing following crossover stenting in main branch and endpoint of left main bifurcation stenting should be evaluated. There are 2 factors to predict side branch occlusion following main branch stent implantation: plaque at the entry of a side branch and eyebrow sign on longitudinal view. There are 2 types of side branch. Group 1 is ostial side branch stenosis only in the main vessel as illustrated in A. Group 2 means plaque truly involved in the side branch ostium as in B and C. Side branches having diffuse plaque around their ostium were at the greatest risk. More than 1/3 was occluded. On the contrary, if side branches did not have plaque involving their ostium, side branch occlusion was uncommon, less than 10% after PCI.
The other interesting finding is a unique eyebrow sign that means spiky carina in the longitudinal reconstruction because of narrower angles at bifurcation as shown in this slide. Based on this paper, eyebrow sign is the strongest predictor for side branch occlusion after main branch stenting. Displacement of Ivas-defined spiky carina induces ostial stenosis in the side branch, as shown in the slide. Practical use of Ivas in left main bifurcation are as follows. Before PCI, during Ivas pullback from main branch, check entry of side branch. If possible, another pullback from side branch is strongly recommended to evaluate plaque distribution. This slide shows Ivas classification of plaque distribution in left main bifurcation. They performed Ivas pullback from both LAD and circumflex to left main. Both the LAD and circumflex size of the carina, that means flow divider, were always plaque-free. The most common Ivas pattern, 62%, involved continuous axial plaque from the distal left main into the proximal LAD and circumflex arteries. In addition, continuous involvement from the distal left main into the proximal LAD is present in 90%. Angiographic Medina classification had a high negative predictive value. After main branch stenting, check guide wire position at the site of crossing. As you know, middle to distal recrossing is highly recommended. If the guide wire is going proximally, stent should be deformed and new carina of stent struts are created following kissing balloon technique. It is important to use both cross-sectional and longitudinal view on Ivas for following assessment. Finally, check incomplete stent apposition, stent deformation, as well as dissection or injury at side branch ostium. This slide demonstrates endpoint of the left main stenting. These numbers are basically two-stent strategy using cipher stent, but these numbers can be applied to current left main PCI. If you achieve greater than 5 square millimeters at circumflex ostium, 6 square millimeters at LAD ostium, 7 square millimeters of polygon of confluence, and 8 square millimeters at proximal left main, rate of instant restenosis is very low, like 5%. Especially if you are not able to achieve 4 square millimeters in ostial circumflex, almost half of the cases developed instant restenosis. In summary, plaque at the entry of a side branch and eyebrow sign on longitudinal view are the good predictors for side branch occlusion. Plaque distribution in left main bifurcation is not always related to angiographic classification. Carina always paired and the disease is diffuse rather than focal. Second wire position is important to obtain good stent expansion without stent deformation. Use longitudinal view to check guide wire passage to the side branch. Try to achieve 5, 6, 7, and 8 square millimeter criteria to minimize instant restenosis. Thank you very much for your kind attention.
Thank you very much, Dr. Honye. I personally learned a lot from your talk. So I think in this symposium, we learned about this new SYNERGY XD stent. We also went through a very cheap case, a complex case using Ivas and different techniques and a good stance to deal with it finally in a successful fashion. And it remains for me now to thank all my co-faculty, Dr. Rosli, Dr. Goran Stankovic, and Dr. Honye for participating in this Boston symposium. I hope you enjoy this program and will continue to enjoy the rest of it. Thank you.